All right, welcome back to Medical Review with Dr. H. Today, we're going to break down a super important, super high-yield topic in cardiology, the 4 primary cardiomyopathies. So whether you're grinding for boards or just need a solid refresher, you're in exactly the right place. Let's just dive right in.
Okay, first things first, let's establish a golden rule right off the bat. The specific thing that injured the heart, whether it's a virus or ischemia or something else, that's often less important than how the heart muscle itself responds to that injury. And that response, well, that's what gives you the diagnosis. It's how we classify everything, and it's absolutely the key to unlocking this whole topic.
So how do we break this down? Super simple. We've got 1 systolic failure and 3 diastolic failures. That's it. Think of it like this. Systolic failure, that's a pump problem. The heart just can't squeeze hard enough. Diastolic failure, that's a fill problem. The heart is too stiff to relax and fill up with blood. This framework, it's going to be our roadmap.
All right, let's kick things off with our one and only systolic failure, dilated cardiomyopathy. And honestly, the name pretty much says it all.
So, I want you to picture the heart chambers just blowing up like a big, sad balloon. The walls get all thin, stretched out, and super floppy. On a microscopic level, your actin and myosin filaments, they need to overlap to get that good squeeze. Here, they get stretched so far apart that they can barely shake hands, let alone contract properly. The bottom line is, it's a classic pump problem.
So what causes this? Well, a lot of the time it's idiopathic, which is just a fancy way of saying we have no idea. But there are definitely some classic culprits you've got to know. We're talking viruses, like Coxsackie. Chronic alcohol abuse is a big one. Thiamine deficiency, you'll know it as wet beriberi. Yep, that can do it. And even some chemo drugs like doxorubicin. And of course, ischemia can be a cause too.
Okay, so how do we manage it? It's your classic bread and butter systolic heart failure playbook. The pump's weak, right? So pretty much every single patient is going on a beta blocker and an ACE inhibitor. That's just standard of care. Now, if they're all fluid overloaded, we'll use loop diuretics like furosemide to get that fluid off. But what if the meds just aren't cutting it? Well, the definitive end-of-the-line treatment is a heart transplant. Okay, 1 down, 3 to go. Let's shift gears now to our diastolic failures. This is where the heart muscle gets way too thick. I like to call these the hypertrophic twins. Now, they both cause a filling problem, remember? But as you're about to see, they get there in very, very different ways. First up, we've got the famous one, Hypertrophic Obstructive Cardiomyopathy, or HOCM. This one's genetic. It's a problem with the sarcomeres, the little engines of the heart muscle. And the key feature, the thing you absolutely must remember, is asymmetrical septal hypertrophy. That wall between the ventricles, the septum, it gets massively thick, but only in one spot. And this big bulge of muscle literally creates a physical roadblock, obstructing the outflow tract.
And this leads us to the absolute classic, will be on your test clinical vignette. You see a young athlete who passes out during practice or game, bam, your brain should immediately be screaming HOCM. Add in a family history of sudden cardiac death, especially at a young age, and I mean, it's a super distinct, super scary presentation.
Now, the management for HOCM is totally unique, and it's because this obstruction is dynamic. It changes. If the ventricle is kind of empty, that big muscular septum can slam shut and block the exit. So the number one goal of treatment is simple. Keep the ventricle as full as possible all the time. How do we do that? 3 big things. First, no more sports, immediately. Second, we slow the heart down with beta blockers or calcium channel blockers to give it more time to fill. And third, tell them to never ever get dehydrated.
All right, now let's talk about HOCM's twin, concentric hypertrophy. This one isn't genetic. This is what I call gym muscles for the heart. It's an adaptation from pumping against the heavy weight of chronic high blood pressure for years. The muscle gets big, beefy, and strong, but it gets thick all the way around. It's symmetric, it's concentric, totally different from HOCM. And the treatment? Treat the underlying problem. Get that blood pressure under control. Okay, time for our last major category, restrictive cardiomyopathy. Now, this is also a diastolic failure, a filling problem. But this time, it has nothing to do with the muscle getting too thick. No, the problem here is that the heart muscle itself gets replaced by, well, gunk. We call this an infiltrative disease. The wall of the ventricle literally gets infiltrated and filled up with stuff that is not heart muscle. We're talking about things like amyloid proteins or inflammatory cells or even iron deposits. And all this gunk makes the heart wall incredibly stiff and rigid like concrete. It just can't relax and stretch to fill up with blood. So once again, we're back to a classic filling problem. So what exactly is this gunk? For your exams, you need to know the big three causes. Number one is amyloidosis. The big clue here is patients often have peripheral neuropathy. Number two, sarcoidosis. You're going to want to look for clues in the lungs. And number three, hemochromatosis. This is iron overload, and the classic giveaway is the triad of cirrhosis, heart failure, and bronze diabetes. For diagnosis, think fat pad biopsy for amyloid, cardiac MRI for sarcoid, and a ferritin screen for hemochromatosis.
For management, it's a diastolic failure, so step one is rate control. But here's where it gets tricky. These patients are often fluid overloaded, but you have to be so careful with diuretics. We call it gentle diuresis. If you dry them out too much, that stiff ventricle won't have enough preload to fill up, and their cardiac output will absolutely tank. And of course, you have to treat the underlying disease itself.
Whew, okay, I know that was a ton of information. So let's take a breath, bring it all together, and put these 4 types side by side. This will really help solidify the concepts.
And there you have it, the big picture. You've got your 1 systolic failure, dilated, the big floppy balloon heart, and then your 3 diastolic failures, HOCM, the asymmetric genetic one, concentric hypertrophy, the gym muscles heart, and finally, restrictive, the stiff, gunked-up heart. Seriously, this is a perfect slide to screenshot for your study notes.
All right, now for the part you've been waiting for. Let's see if you can put all this knowledge into practice with a couple of rapid-fire clinical cases. Ready? Let's do this.
Okay, case number 1. You have a 17-year-old kid, a basketball player, who collapses right in the middle of practice. He admits he's been getting dizzy when he really pushes himself, and here's the kicker. His grandfather died suddenly, out of the blue, at just 30 years old.
Okay, take a second and think. Based on that presentation, what is the number 1 diagnosis you should be thinking of?
If you said HOCM, Hypertrophic Obstructive Cardiomyopathy, you are absolutely correct. Nice job. I mean, this is the textbook case, right? Young athlete, syncope with exertion, and that tragic family history of sudden death. It's classic HOCM.
All right, let's try another one. Case number 2. You've got a 55-year-old guy who comes in with all the signs of heart failure. Shortness of breath, swollen legs. You look at his chart and his past medical history is significant for 2 big things, cirrhosis and bronze diabetes. His echo confirms a restrictive pattern.
Okay, so the echo already told us it's a restrictive cardiomyopathy. But the real question is, what's the underlying cause? What's the gunk? And the answer is hemochromatosis. That classic triad, the cirrhosis, the bronze diabetes, and the heart failure, that should make you think of one thing, iron overload. It's a perfect example of how you have to look at the whole patient to figure out what's going on with the heart. And there you have it. You know the players, you know the playbook. The only question left is, which one are you going to see next?